Hi everyone, welcome back. So today's topic is femoroacetabular impingement, otherwise known as hip impingement, and this was recognised for the first time in 2003 by an orthopaedic surgeon called Dr. Reinhold Gans. And he actually recognised this hip impingement as a cause of osteoarthritis while developing an open surgical dislocation procedure. But femoroacetabular damage has, there have been kind of reports of this for actually over 100 years. So, it's not something that's just suddenly appeared. So with regards to the anatomy, as we know, the hip is a ball and socket joint, which basically allows for multi-directional movement and rotation between the femur, the thigh bone, and the pelvis. The acetabulum of the pelvic bone forms a socket and is lined with a strong kind of fibrous cartilage, which is called the labrum, kind of like you have in your shoulder. And this cartilage helps to stabilise the joint by basically providing a tight seal for, the ball to fit into. So the ball is formed by the head of the femur, and this is covered with articular cartilage to provide a smooth and low friction surface that allows for easy movement. Now, the hip joint has a complex musculature and major nerve supply, because you've got the femoral and sciatic nerves running through there. So, this, it's a good and bad thing. It can actually make injury more likely because of how complex, these systems are. So, in terms of FAI, or femoroacetabular impingement, what is it? Okay, so FAI basically occurs when there is abnormal movement between the hip bones. So abnormal movement between the head of the femur here and the socket, which is the acetabulum of the pelvis. And this abnormal movement occurs due to the development of bone spurs, or little growths of bone, which will occur either around this femoral head or the acetabulum. Sometimes, the bony spurs will occur in both, which and these bone spurs can lead to labral tears. So that's, tears in the cartilage, and also deterioration of the articular cartilage that coats the head of the femur, and this is known as osteoarthritis. And so FAI is one of the most common causes for hip pain in young and sort of middle-aged adults. Okay, so we have 3 types of femoroacetabular impingement. As you can see here, so you can see the ball and socket joint very clearly here. So in a normal hip joint, you have the ball and the socket that fits nice and snug, allowing for a good range of rotational movement in the hip. and everything's nice and smooth. There's no bony growths on this joint at all. Then we actually have what is known as cam impingement. So cam impingement is where the head of the femur, or the ball, isn't as round as it should be, so it can't rotate smoothly within the acetabulum, or the socket. And this is where a bone spur will develop on the upper edge of this femoral head, which is known as a cam deformity, and it basically grinds the cartilage when the joint moves. And this type of impingement is actually linked to the development of osteoarthritis, and certainly osteoarthritis, in younger adults. So then we have the second type of impingement, which is pincer impingement. Pincer impingement is where the bone spur extends past the normal rim of the acetabulum. So you can see it on the edge of the acetabulum here. And this is known as a pincer deformity, and it can cause the labrum, which is that cartilage lining the socket, to be pinched under the prominent rim of the acetabulum. So it can be pinched around here. So then we have the third type, which is combined or mixed impingement. And so this is basically where both the cam and the pincer type of impingements are present, and this actually occurs in about 70% of cases of FAI. Now, cam impingement occurs more often in males, while the pincer, which was the one where the bone spur is on the rim of the acetabulum, is more common in females. And this is most likely due to the anatomical differences in the pelvis between male and female. Okay, so if we think about the causes of femoroacetabular impingement, we are looking at things like abnormal development of the hip bones during childhood, which can lead to either that cam or pincer deformity, which causes joint damage. Many people are asymptomatic, but when symptoms do occur, then there is almost certainly at that stage, damage to the cartilage. There is quite a high incidence in young white athletes where the hip is subjected to forced loaded flexion and internal rotation. So we're looking at things like hockey, football, and also equestrian sports. There is possibly thought to be a genetic link, as there seems to be an increased incidence in siblings. And also anyone who sort of does repetitive or prolonged squatting, twisting of the hip, so getting in and out of cars, or sitting for prolonged periods, are they seem to be at a higher risk of getting this type of impingement. Now, there are other diagnoses that FAI can be mistaken for. So we're looking here at things like piriformis syndrome, labral tear without the impingement. Adductor muscle strain, which is strain of those muscles along the inner thigh. And if we sort of think about we just mentioned about equestrian sports, you're using the adductor muscles an awful lot in those. Sciatica, as we said, you've got the sciatic nerve that runs through that hip joint. Athletic pubalgia, which is otherwise known as sports hernia or Gilmore's groin. Any tendinopathy, which involves the gluteus medius, gluteus minimus, which sit on the outer hip, or the iliopsoas, which is one of your hip flexors. Stress fractures, osteonecrosis of the head of the femur, the ball of the joint. Any other impingements such as anterior, inferior iliac spine, the ischiofemoral and iliopsoas, or also any kind of loose body, in the joint, could be mistaken for FAI. Now, in terms of symptoms, there are quite a few. So obviously pain. There's going to be pain in the groin area and around the outside of the hip, which again is why it sometimes gets confused with, issues with the gluteus minimus and medius, or with Gilmore's groin. Sometimes the pain will extend to the upper buttock, lower back, or below the buttock and posterior upper leg, which again, could kind of mimic a little bit of sciatica. There may be a stabbing pain when twisting or squatting, stiffness, decreased movement, and therefore, there may also be like limping. And these symptoms, they can come on suddenly or, gradually kind of get worse. There's not really any kind of pattern, but they do tend to get worse with prolonged sitting. And the real test to see, if you think you might have this type of impingement is if you lay on your back, bring your knee up towards your chest, and then rotate the hip inwards. So you'll bring your knee up and then you're going to inwardly rotate the hip to bring that knee up towards the opposite shoulder. If you're getting pain when you do that, then, impingement is more than likely. So yeah, you need to obviously then get it seen to. Now, in terms of treatment, obviously avoiding activities that cause symptoms. So if you're down the gym every day doing squats, you might want to ease off those. Obviously, it might be a bit difficult, if you're something like, say, a taxi driver, for example, or a delivery driver where you're in and out the car. Anti-inflammatories, obviously, to reduce pain and inflammation. Ice packs, again, to help reduce inflammation. And, if symptoms are persisting, as I've said, do seek medical attention to avoid further damage to the hip, because, as I've said, this type of impingement, it can lead to early onset osteoarthritis. Other treatment options are obviously physiotherapy or sports therapy. Doing exercises, getting massage may improve the range of motion in your hip, strengthen those surrounding muscles that support the joint, and also improve posture. Which if you're limping, your body's going to be out of alignment. and therefore these things help to relieve some stress on the injured labrum or cartilage. You can also look into having cortisone or hyaluronic acid injections, but again, these are going to be temporary. Now, you can have surgery, which is recommended when symptoms persist, for a period of time despite having tried the conventional treatments. The surgery will correct those bony abnormalities which cause the impingement, and also correct soft tissue lesions, so things like your labral tears. And it will really correct the way that femoral head fits into the acetabulum, reducing the contact to improve the range of movement. Surgery would usually be done arthroscopically due to obviously reduced complications and improved recovery time and positive outcomes. And basically what they do, they'll just shave the bone growth off the femoral head, trim the acetabulum and do the labral repair. Now, in terms of outcomes, while surgery can reduce the symptoms and prevent further damage to the joint, if there's any severe damage due to delayed treatment, this may not be completely fixed by surgery. So again, I'll stress the importance of, that test that I mentioned, and if you feel that you may have FAI, you do need to get, some medical input there. But most athletes, will return to their previous level of activity, following obviously the recovery period. Okay, so big question. How can massage help with this type of impingement? So while massage can't be used as a standalone treatment for FAI, it does have some benefits when combined with other treatment options. So, the friction type therapy will certainly help reduce adhesions, which obviously if you go down the surgical route is going to be, the risk of those is going to be increased. But also adhesions that form with repetitive injuries, which then cause pain and stiffness. Also, scar tissue actually thickens tendons, which then increases the risk of impingement. So by getting some massage, you'll actually be helping to reduce, the risk of subsequent impingement. But we know massage, also it's going to help, to restore normal range of movement by gently stretching the muscles, using those myofascial release techniques, which can help loosen any tight connective tissue around the site of the impingement, and obviously the connecting muscles. It will also help to correct any of those dysfunctional patterns that may occur as a result of the pain. So if you've been limping, you're going to find that certain muscles are starting to compensate, which obviously then can lead to additional problems in your good leg, or also particularly in your lower back. And so it can help to correct these sort of poor patterns that we get into, which will also, help improve pain, and, just get our posture back to what it should be. It can also be, as we know, very beneficial in controlling chronic pain, which is also going to help you, in the recovery period, and really just helps strengthen the muscles, which again just helps reduce further injury. But in terms, we've said it can be used sort of combined with other treatments. Certainly, there are some exercises that you can do, which, whether it's to try to sort of strengthen the surrounding muscles, when you first realise that you have impingement, or whether it's, in the early stages of sort of post-surgical recovery. So I'm going to go through those now. Okay, so the first exercise is the good old clams. So lying on your side with knees bent, you're going to then, while keeping the feet together, externally rotate the bad hip, bringing that top leg upwards, but keeping the feet together. So there's external rotation at the hip, and then bring it back down. The next one is a single leg bridge. So lying on your back, with obviously one knee bent and the other leg straight. We're going to be lifting the buttocks off the floor using that leg that is bent. Okay, then we have hip extension exercises. So for this, on all fours, you're really just going to extend one leg upwards and keep that knee slightly bent, this top knee. If it's initially too difficult to keep the leg straight, because this will be your bad leg. If that's too difficult, then you can do it by keeping that top knee bent. And then the last one is side steps. So just taking small steps sideways while keeping the toes pointing forwards, maintaining a slight squatted position. You don't want to go into a deep squat. And once pain subsides, and these exercises are easy, then you can actually start to use a resistance band, on the clams, and certainly the side steps. You can use a resistance band in order to work those muscles that little bit harder. So that is really sort of basic information on femoroacetabular impingement and how you can kind of deal with it. Obviously, once you've done those exercises, obviously stopping, if they are painful, progressing slowly. Then obviously as you get stronger and you have no problem doing those exercises, maybe you've started using a resistance band and you're finding that easy enough, then you can start to, deepen the squats a bit and gradually progress that way. So as always, any questions, feel free to comment down below, or you can message me through my Facebook or Instagram. I'm on both of those as the Medical Massage Lady, and I will do my best to answer you. Or feel free to subscribe, because I will be doing quite a few more sports injury type posts. So that's really it from me today. So until next time, take care.